Hi, everybody. Welcome to the Skilled Nursing Facility Consolidated Billing, or SNF CB, Reading the CMS Files webinar. SNF Consolidated Billing is one of our top denials, and on every webinar, we're asked about the files and how to read them. We were also asked for a brief overview for this webinar, so we'll go through that. I'm Tom Ryan with Provider Outreach Education, and I'll be your presenter today. Today, I'm joined by Ashley from my team. Ashley's going to help me with the questions and the information in chat. She's going to give you some additional links. If you would like the presentation material from today's event, please go to our live events page and download it. We will remove that presentation material either later today or tomorrow, and then you'll have to wait until we post it as an encore presentation. Encore presentations are typically available within a week or two after the event. Please remember to review the disclaimer at the end of our presentation. What's our goal today? What's our objective? The goal today is to introduce you to the CMS files so that you know when you can bill correctly, so that you bill the SNF, the skilled nursing facility, or will you bill Medicare? We want to make sure that you understand that basic question. So I will do an overview, then I'm going to show you the files and I'm going to explain them. Then I will actually go ahead and give a couple of examples and we'll get into your questions. The reason that we're providing the overview today is because a few of you did ask questions about general information. Actually, I have 4 of you that stated you were new and you're not familiar with skilled nursing facility consolidated billing. Keep in mind, this is not billing for a skilled nursing facility. That is a separate concept. That's how they get the claim to Medicare. Skilled nursing facility consolidated billing is a little bit different, and we're going to define that next. So let's begin with what is skilled nursing facility consolidated billing. This is a bundle concept. That bundle concept means that everything goes to the skilled nursing facility and they're responsible for the care. That means they're responsible to receive payment and pay outside vendors. They must coordinate care for patients in their facility. Remember that the care must be within the scope of a skilled nursing facility. Otherwise, it is separately billable to Medicare, and that's what confuses people the most. For the most part, though, it is the SNF's responsibility to receive payment from Medicare and then to bill, and then to send payment to all of the other providers. This means that Medicare makes one payment under the covered inpatient stay for Part A. So SNF consolidated billing, why was this enacted? I will tell you, we got a pretty good comment on this one, and someone said it was enacted to annoy me. I'm glad that that's your opinion. Hey, we recognize that. It really wasn't enacted to annoy you. What it really was enacted to do was to assign the care to the SNF and to make sure the SNF is aware, the skilled nursing facility is aware of all the care that's going on. So they want to oversee and coordinate care. Now, who is responsible? Whatever the skilled nursing facility is that the patient is inpatient in a Medicare Part A stay. We'll get into that in just on the next slide there. So we'll get into what a Part A stay is. The goal for the patient was to reduce their out-of-pocket, so they're not paying that 20% coinsurance for all Part B services along with other Part A stuff, which could be additional expenses. It also eliminates duplicate billing. If something's going on, we don't want to repay for it, so that's what consolidated billing, the goals were. This ultimately helps protect the Medicare Trust Fund and the patient's expenses. So there are 2 types of stays that you have to be aware of when you're talking about skilled nursing facility. The first is what Medicare refers to as a Part A stay. This means that Medicare is covering the inpatient stay, room and board, nursing care, etc. For each benefit period, I'll define that in just a moment, Medicare pays 100 days or considers 100 days. There is also what is called a Part B stay. These are otherwise covered Part B services when Medicare is not paying the inpatient care under Part A. It does not mean the stay is not medically necessary. So it could be day 101 or more. It could be that somehow the Part A payment criteria were not met. So for instance, there has to be a 3-day qualifying hospital stay before the skilled nursing facility stay. If that 3-day qualifying hospital stay isn't met, then the skilled nursing facility will not receive payment. When that happens, the patient automatically enters into a Part B stay. A benefit period is the utilization days for a Part A stay. It does have to be reset, and it can be reset more than once a year. Okay? It does apply deductible for hospitals, etc. Benefit period. Benefit periods for Medicare do incorporate Part A and B stays for a skilled nursing facility. This is important because until the 60-day lapse in all inpatient care, the 100 skilled nursing facility days does not restart, which means you cannot have a Part A stay. Why is that important? If a patient remains in a medically necessary stay, even if Medicare is not paying, so they're in an inpatient medically necessary stay, they will not get a new benefit period. And this can be for a lifetime when it comes to skilled nursing facility. Example is a tube feeder meeting all of the Medicare requirements. Because they remain on that level of care, they'll never get a new start to a Part A stay, which means they never get a second 100-day stay or anything, however you want to say that. There has to be a 60-day lapse of inpatient care. We do recommend that if you want to learn more about the benefit period, we have a couple of courses on it, and you take a listen to those. They are on YouTube. All right, the SNF's payment responsibility. The SNF is responsible for paying Medicare covered services, clinical social work services, incident to services, and preventive and screening services. Now, some of those are included in the SNF prospective payment, which simply is a per diem rate given to the skilled nursing facility, while other items are outside of that, such as preventive and screening services. Once the patient uses that 100 days and they enter into a Part B stay, the only services that are billed to the skilled nursing facility, so long as they remain in a medically necessary stay, are physical, occupational, and speech language pathology. The reason for that is what the patient is in the skilled nursing facility for. That's what the design of skilled nursing facility is. They don't need as much as inpatient hospital care for medically necessary stays, but they do need to continue with skilled level of care. And that's what the therapy services will do for them. Excluded services. Medicare has two types of excluded services when it comes to skilled nursing facility consolidated billing. First is the Medicare excluded service. This is a lot of times what you think of when you think of something that Medicare will never, ever cover. The law said no. This is not a part of our Medicare program benefits. It is excluded, and you do bill the patient for this. A SNF consolidated billing excluded service is different. This type of an excluded service simply means that you will bill it to Medicare as long as it's not a coverage exclusion. So it is outside the scope of a skilled nursing facility. CMS uses files on their website to do this. What they do is put together a list of procedure codes that should be billed to the skilled nursing facility, or in some cases should not be billed to the skilled nursing facility. So we're going to take a look at those in particular. All right. So of course, because CMS wants to make this simple for everyone, they've developed different files, and the files are what we're going to take a look at next, and we're going to talk a little bit about them. What are you trying to do when you determine using these files? Why are these files important? First, you're trying to determine what procedure codes should be billed to the skilled nursing facility versus what procedure code should be billed to Medicare. This is not about excluded services, which should automatically be billed to the patient. A couple of things to keep in mind. Even if something is listed on the file, but Medicare is not paying for it because the skilled nursing facility is excluded, that stay is excluded, they didn't meet one of the coverage criteria, you will fall back to the same as if it's outside those days. They're not in a medically necessary stay. Okay? Now, what other things do you need to consider? Where is the location of the service? Is it in an ER? Is it in a hospital? Is it in an office? Is it in a freestanding diagnostic facility? Where is it physically located? That drives certain portions of the files. So lots going on there. Before you get to the files, take a minute though. Determine if you need to ask questions of the skilled nursing facility. In most cases, you probably will. So you know the patient is in a skilled nursing facility, they're temporarily staying there. What are you going to ask them? Well, is it medically necessary? Are they in a medically necessary Medicare stay? If the skilled nursing facility says no, then these rules don't apply. If they say, well, it's medically necessary, but they didn't qualify, they didn't have the 3-day qualifying stay, then these rules don't apply. If they say, yep, it's a non-covered day because these rules are done, meaning outside the 100 days, so they've got all and used it all up, then you say, oh, okay, so it's medically necessary. And then you need to check, is it for PT, OT, or SLP? And should that be billed directly to the skilled nursing facility? So there's a lot of questions that you go through. A couple of things to do. One, ask your patient. Be careful when asking your patient with the terminology you use. One office gave me a great recommendation and they said, we ask, are you temporarily staying somewhere else? So along with asking, has your residence changed, which they'll say, nope. Are you temporarily staying somewhere else? Well, yep, I'm staying in this facility. I'm staying at this nursing home. Okay, now you need to ask a few more drawing questions. The patient may not always know everything related to that, but it would give you an indicator as to contact the nursing home and go a bit further. I was specifically asked about eligibility on our system. And yes, we do have a system called SNAP, the Secure Net Access Portal. The Secure Net Access Portal is available on our website. And in the Part A deductible section, there are a couple of pieces of information that are available to you. One, the SNF spell dates and the deductible remaining, the SNF copayment amount and days remaining, and the SNF stay days and the billing NPI. Now, here's the catch to that. This information is available based on a claim having processed. So this first skilled nursing facility claim has to be in our system before this information is available. So it has to process through this system and be approved. So just a lot of basic pieces of information. Before I leave this, I do just want to show you that on our website. Our website's wpsgha.com. This is SNAP right here. It's the secure section. It's not a separate website or a separate area. It's just this login section. Now, we can't go in and show you that, but I can use the portal user manual to highlight the information I was just talking about. So if we come into the portal user manual, you can download the full PDF version up here, or you can scroll through and pick a section. I'm going to scroll down and pick a section. I'm going to come down to transactions way down here. And under that, or I'm sorry, come down to patient, not transactions, patient, and do eligibility check. If I open that up, you'll be able to read through all about the eligibility check, find out where all the information comes from and all of that pieces of information. If you don't like a fast scroll, I really do recommend looking away at this time. Once you enter all of the information and go ahead and hit enter, it will display a screen. The screen will have your basic boxes that are going to look like what's here on the screen on the top. You'll see a dark blue box with white writing. That's where you're at. In this case, it's summary. The next item over is the Part A deductible screen. This is what we're looking for. So the Part A deductible screen contains more than just the Part A deductible. And I'm just going to scroll down to it. This is where you're looking at the SNF spell days, the SNF copayment. These days are what you're looking for right here. And the three items. Now, as I said, if the skilled nursing facility has not billed their claim yet, there may not be anything here. There may not be a single thing in any of those fields. But it is an option and where you would find information, so hopefully that helps answer the question regarding that. All right. So during a Part A stay, CMS does have a set of files that you'll want to use. Now remember, it says that the care has to be within the scope of a SNF. And how does that work? Well, first of all, it is established by law, and we're going to look at the files in just a moment. Now, the reason I'm going to do that is I'm going to differentiate between the Part A and B files. To start with, though, if you do not have your procedure code, you need to get that. That's what's going to start either A or B files, doesn't matter. I need the procedure code. So will you. Then you're going to look at the technical and professional component. So does it have a modifier TC and a modifier 26 that has the potential to be billed? We'll find out why that's important next. Also, is it an add-on code or associated to another service? I'll give you an example. Add-on code is simply something within the CPT guidelines that says, in order to bill this, you must have this. You must bill this procedure to bill this procedure. That's an add-on code. Associated to another service means that in order to get this procedure done, this must happen. Give you an example. In order to get an MRI done from a freestanding facility or at a hospital separate from the skilled nursing facility, you have to take an ambulance to get there. That's an associated procedure. The ambulance run is associated to the MRI. Ultimately, I've got to get them there to get this procedure done. So you do have to determine that. We'll talk more about those in just a few moments. There's also a set of files that are used for Part B. Now in the Part A files, when we look at what should be billed, you'll see that they are pretty much always going to say excluded services. There's one piece of information that's an included file. On the Part B files, or the Medicare, billed directly to Medicare, you'll notice right away that most physician services are there. Well, that's because they're professional, and skilled nursing facility by definition is a facility service. Most emergency room services. People laughed a little bit at this one because they said, well, the verbiage isn't right. It's all emergency room services. And the answer is that's not true if it's not billed correctly. And we'll show you that in just a little while. There's also services that are just simply outside the scope of a skilled nursing facility. Some of those would be dialysis, for instance. Medicare excluded in telehealth originating site fees. So it really just depends on what you're looking at. There are Part B files, which are actually labeled Part B. There are 4 sets of files. The first 3 are exclusionary files, and the 4th one is an inclusionary file. The 4th one is just to say, hey, these services must be billed, which are PT, OT, and SLP services, must be billed back to the skilled nursing facility as long as they're in a medically necessary stay. Please remember they do have to meet the Medicare coverage guidelines. It's not like you just say, hey, we're going to bill them. They do have to meet all the Medicare coverage guidelines. At this point, what I'm going to do is flip to the CMS website. You guys are going to start on slide 15. We're going to go through some slides 16, 17, etc. But I'm going to use the website. I'll try to tie it back for you. On slide 16, you will see steps to locate the files. These files, again, are available on the CMS website. So the first thing you have to know is go to cms.gov, select the term Medicare. Oops. I went down one too many. Then select coding and billing. We're talking about skilled nursing facility consolidated billing, so SNF consolidated billing or SNF CB. By opening that section, you will come directly to the files. You can read all about it, and all the files are located on your left side of the screen. The information's on the right. I'm just going to scroll down just so you can kind of see. If you want to learn more about actual SNF billing, that's where the consolidated billing stuff comes in. So let's go ahead and just say, here's the Part B files, which we talked about. Here's the Part A files, which I did mention as well. What I'm going to do is take a deeper delve into these files to hopefully help you understand it a little bit better. So we've located them on slide 16, and now we're going to move to slide 17, and you're going to see Part A MAC updates. So if we read this, you'll see they're annually updated, and then it'll say Part A MAC update. When you open it, always take a look at this page. If there's something that has been in effect or changed since these files were first published, it will tell you. So effective on 1/1/2026, here's some information you need to know. Then if you scroll down to the bottom, you get two different files under downloads. I will tell you, if you're not familiar with the major categories, if that doesn't sound like a term you're familiar with, start with the bottom one, and that is your PDF version. And this really explains the Excel file, which is the other file that we're going to look at in just a few moments. And it says, okay, here's what you have to know about each major category. So if you're reading and trying to learn about major category 1, we know they're exclusions because they're beyond the skilled nursing facility. Okay, they're beyond the scope of what a skilled nursing facility is expected to be able to do. But don't stop reading. Keep going, because then it says they must be provided in an outpatient hospital or critical access hospital. Did you note that it doesn't say they can be provided in a freestanding facility or anything like that? The only time they're excluded are when they are at an outpatient hospital. So that's some key things to keep in mind. They must be billed for the same data service. And then you can bill directly to Medicare. Gives a little bit more down in here and just some general stuff. Here's the files and how they break out and what major category. If there's any certain category that you need to know information, so such as F, this is an inclusion versus an exclusion list. Why are these included with the skilled nursing facility stay versus everything else, which is an exclusion list? Because there's so few surgeries a skilled nursing facility can do that it's easier to list the included ones. Emergency services, caveat here, they have to be billed correctly with the correct revenue code. Revenue code 045X. If they are not, this causes issues because then the SNF is responsible for it. So we did have a couple of questions that said, well, why are the ER services included? Well, the emergency room services are included when they're not billed with the emergency room revenue code. I don't know exactly what's going on with your billing. I didn't get a claim example or anything to look at from there, but that's the first answer that we have. And then you can read through all the different caveats and things that go with it from there. So then you go through and say, okay, that's great, but what does this file really look like? Like, here's a great explanation, but what does it look like? So if we back and we select the top one, it's going to ask us to then open a file that is compressed, and this is what that file looks like. And then you get to open an Excel file. Now, these are the same Excel files. One is just a comma space and one is a regular Excel. The XLS is the regular Excel that I typically will open and use, just myself. And then what it does is it actually breaks down by columns the procedure codes and all of the different information that you'll need. Here's an example of what that file looks like. So you can see all the procedure codes, short descriptors, and then the major categories, which you take back and you put into the PDF document that we just looked at to find out more information. So there's a lot of stuff that goes into this when we look at this different pieces of information. So for instance, we could say Control F, and I want ambulance. That's wait, there's nothing for ambulance on here, but I saw ambulance on the other list. Oh, there it is. There's ground ambulance. And it says, wait, this is major category 1H. Wait, with applicable application to major category 2. Remember I said this is an associated service, so it's really dependent upon what other services you're having done. All of that again would be explained, oops, nope, in this one. And so if you wanted to go and you wanted to learn more about ambulance, start here and then figure out, okay, which major category does the end service result in, which is the associated service? And is it in one of these or 2A? If it is, then the ambulance trip is billed to Medicare. If it's not, then it's part of SNF Consolidated Billing. So that's how it works, just as an example for that. Along with that Excel file, there's also the Part B files, and these are slightly different. Now, these are the Part B Mac update files, and they're located on the first part of the screen, even though we scrolled by them. Make sure that you stop and you read this page. Again, here's where it'll tell you add to file 1, add to file 4, all of those different things, and you want to make sure you have the right files. What's important to know is that as we scroll down through, there are 4 distinctly different files, and each file is used for a different purpose. So we can start with file 1, and file 1 is for what are called physician services. These files are never, ever billed to the facility. So we're just going to wait and let file 1 open for a second. So this is considered a professional service, which means it's automatically billed to Medicare. No modifiers appended, nothing, just bill it to Medicare. If I want to see if something is on here, I can hit Control F and do a certain procedure code and say, okay, yep, this makes sense. An outpatient office visit, yep, that would be billed directly to Medicare. Now this should be, again, outpatient office visit in an office setting, not outpatient office visit in a skilled nursing facility setting or an evaluation and management in a skilled nursing facility setting. So you want to make sure you're submitting the right codes. Okay, here's your emergency department codes, all of those different types of care codes. So that's how you would read that. These again are professional services, will always be billed directly to Medicare. Then if we leave that, sorry, we'll open file 2. Oops, get back to the website. You're going to open file 2. These ones are a little bit different in that they are services that may be billed to Medicare, but also require a portion to be billed to the skilled nursing facility because they have professional and technical components or facility components. So this is when you have to bill any procedure coding here has to be billed with a modifier 26 to Medicare and a modifier TC to the skilled nursing facility. We have had different skilled nursing facilities say, I don't really need the modifier, but I do need it to be billed appropriately. That's up to them. That's not up to us to decide. I will tell you Medicare does require that you break this out and tell us it's a professional component. If you bill one of these codes without the modifier 26, Medicare will deny the code. We're denying it because you're billing a global code, which means you're asking for reimbursement for the technical component as well, which this file tells us should go to the skilled nursing facility and be part of their rate. So also, one of the questions is that they have these services being denied by the skilled nursing facility. I don't know what you're billing them, but here's one question. Are you asking them if they need the modifier? Are you asking them what you need to do to get them billed when you must split bill a code? Again, split the bill between Medicare and the skilled nursing facility to make sure it's billed correctly. Again, those are your modifiers. If you're not, I really would encourage you to do that because you may not always have the right information available, or you may not be able to get what they need. All right, so that's just a bit of information on that one. Um, the next code is going to be back on the website, and it's going to be file 3s, which is ambulance codes. This one causes a lot of confusion because when we look at file 3 as an ambulance provider, you say, oh, look, all of my codes are billable to Medicare. Well, yes, that's true, right? Here's my ground. Here's my billable ALS codes, my billable BLS codes, my AIR codes. That's great. But what does that mean? Did you find out if this is associated with another service which must incorporate this before? So remember I used the MRI example at a freestanding facility, or maybe a mobile MRI? These are not billable to Medicare. By definition, it has to be done in a hospital or critical access hospital. So with that, you would bill this as part of the skilled nursing facility charge. The skilled nursing facility wraps these charges into whatever the procedure was. In our example, it's the MRI. They then bill all of that to Medicare with that incorporated charge, and they pay you back. A skilled nursing facility, on the other hand, cannot bill these transport codes. Inpatient care cannot have a transport code billed on it. That's where some of the confusion comes in, because you go to build a skilled nursing facility, the skilled nursing facility puts a rev code 540 and one of your transport codes on there, and it gets denied. Their claim gets returned saying, no, that isn't going to work. And that's because it is part of a different procedure and must be incorporated into that. Unlike when you have an MRI done at a hospital. Because the MRI was done at a hospital, these ground and air codes are then billed directly to Medicare. Now, I did have a whole bunch of questions from ambulance suppliers on this, so I summarized, talked them all up into that explanation, and hopefully that makes sense. If not, please put some more back in chat. Okay, so that's file 3. The last file, or the next file, I guess, would be file 4. And I want to point out that these are Part B state only therapy codes. What does that mean? That means that these are the therapy codes that have to be billed back to the skilled nursing facility, regardless of whether or not Medicare is paying. And you can see there's a variety of different codes listed. If you say, wait, my code is not on this list right here, and they're in a Part B stay, Medicare isn't paying, then do not bill the skilled nursing facility for that code. So sometimes you'll even hear me, as I'm doing education, say, well, what's the code you're going to bill? What's the code being billed at the end destination? Because that's what drives us in this factor. So SNF consolidated billing in and of itself is a huge topic, and there's a lot that goes into it. I gave you some of the basics of it so far. I've shown you the files and where to find them. If you're looking for more information, slip back out here for a second to the PowerPoint. There we go. I do recommend taking a look at all of these different pieces of information. Now, I will tell you the best practices guidelines. This page is designed to give you sample agreements between the SNF and other providers to make sure everything gets billed correctly, because it does affect the skilled nursing facility billing. Someone did ask a question on that, and it's the method in which a skilled nursing facility bills versus most other providers. Remember, inpatient claims are billed on 30-day increments, and the first increment must process before the second, must process before the third, must process before the fourth. That would be for 100 days. So that means that a skilled nursing facility would have to bill it, and it has to get through the adjudication process before they can bill the second 30 days, which would be actually day 30 or day 31 through 60. That's why I said it's got to be in the system. That one screen that I showed you, I said it's not in the system. You're not going to be able to see it. That's one of the problems. So best practices helps with communication. If you want to know more about actual skilled nursing facility billing, that's what the prospective payment system is, or the PPS stands for. We did have quite a few questions come in on that, but I chose not to answer them as they're not related to consolidated billing. Always like the historical questions just so you can get a little bit more information. All the questions are still relevant, so go ahead and take a look at that. The billing reference and the consolidated billing are what we have available for you. So there's a variety of different things like that. One of the things that I want to start with when we enter into the question and answer period, I'm going to answer some pre-submitted questions. Then Ashley will take whatever questions we have in the chat. But the first thing you have to know is that there are payments that are taken back. Yes, I understand it's an overpayment. What happens with the take back is that you have filed a claim. You did not see anything for skilled nursing facility on file. The skilled nursing facility claim then processes. Now remember, they have to wait a longer period of time. It's probably 45 days before they're actually filing their claim. Then they have to wait 14 days for us to adjudicate it if it was filed electronically. And that's pending that nothing else happens in the process. Looks good. Now we're actually at 60 days or almost 60 days. You've already got your claim, you've been paid, and all of a sudden you get a take back. You get a letter saying, hey, you owe us money. We paid you not knowing that this skilled nursing facility was going to file a claim, which causes this form of bundling, the skilled nursing facility consolidated billing, to come into effect. That means we're required to take money back. However, that initial response is what is called an unsolicited response. It's the communication hub, the common working file, or CWF, communicating directly to the overpayments, or HIGLAS, the the accounting system HIGLAS. I can't remember what the acronym actually stands for. I apologize for that. But HIGLAS will automatically set up an accounts receivable and start to initiate that process. And anything to do with someone manually going in and trying to override or look at it, because this claim came in, it is affected by consolidated billing. You had one that was affected. Now we're going to take our money back. If that happens, yes, you can do an appeal if need be. You could also maybe add a modifier if need be and get part of that money to be kept. So for instance, you build for one of those procedure codes that says I need to do a modifier 26 in TC, but you originally build it as global, but you really should have built it this way, which is with the 26 to Medicare. You can actually do that, do the overpayment appeal and say, let me keep the money for this 26 portion. This would have been the correct billing. Hopefully all of that makes sense. Based on the question that I got, I'm hoping I hit everything you guys needed. Next question. Should you rebill only services for inpatient care with the correct place of service when seen in the office? Okay, so let's start a couple of steps back. One, yes, this can cause an unsolicited response, and this would be for an E&M service, evaluation and management service, billed with a outpatient code. So let's just use a 99203 or a 99213. One is for new patient, one is for established. It's mid-level codes. I know that I'm not giving you the full range. Okay, so you bill those. You bill, oh, okay, now all of a sudden a claim comes in and what happens? Well, first, even if you should be able to bill Medicare, you cannot bill the place of service 11. You must bill the place of service 31 and the correct procedure code that goes with that, which is a nursing code. So when we look at that, we do want to make sure that we're following that using place of service 31 and a nursing facility code. That's why some of the takebacks occur. It's just saying, hey, this wasn't done in an office setting. Oh, wait, it was, but Medicare requires it to be billed as a skilled nursing facility because it was inpatient in that way. So even though they're coming to your office for this service, it doesn't matter. The inpatient is what's important in terms of what Medicare sees. For those of you that are not familiar with that, take a look at the Medicare Claims Processing Manual, Chapter 26, and read the place of service sets. This is under a special billing situation, which is under the complete section down below. I really do recommend taking a look at that. I'm actually going to place the Medicare Claims Processing Manual stuff into the chat. If you could pull a link for me, I don't have the link available, but if you could pull a link for me, that would be great. Okay, if a patient, the next question related to that was, if a patient comes to our facility from an office visit, how does that get billed? Well, if they're coming to your facility, I'm not sure if it's before admission. They're not even in the SNF yet, which is possible, in which case it would be billed separately. I'm not really sure when they're coming to your facility. On the other hand, if they're coming back from an office visit or something like that, follow the instructions I just gave. For professional services, again, we did look at it. Want you to keep in mind, and this particular person mentioned outside the first 100 days. So I'm assuming what you mean is they're no longer in the Part A stay, and they're coming to you for a professional service in your office or your clinic. That is different. Remember, the Part A no longer applies, right? Their Part A isn't paying, so therefore that isn't part of it. Now in this case, you could go with a 32, not a 31, 32 to indicate that Part A is not covering the inpatient care if you see them in the skilled nursing facility with the nursing facility codes. On the other hand, if you see them in your office setting, which is what was given to me, it's a clinic or an office, then yes, you would bill the correct evaluation and management service code, so new patient or established, and you would bill outpatient, the 99201 to 205 and the 99211 to 215 codes, and you would bill place of service 11. Place of service 11. That's because the inpatient isn't being covered by Medicare anymore. We're not saying it's not medically necessary that they're inpatient. On the other hand, what we're saying is Medicare's not covering it. Also, if Medicare's not covering it because of the coverage exclusion, they didn't make the 3-day qualifying stay, then you'll automatically get a default back to 11 with the correct evaluation and management codes that go with that service. I'm going to have Ashley just kind of think through this. She does a lot of the evaluation and management education. I do not. So I want to see if she has anything to add to this. Again, she may not, but we'll just see. Hey, Ashley, anything to add?
Hi, Tom. No, I don't have anything to add.
All right. Key things to remember: document, 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 document. And the reason that I say that is, what you want to do is document it that you've contacted the skilled nursing facility, and are they in a Part A or a Part B stay? You know, was it met? Has it something that the 100 days has lapsed, or was it something that just, hey, never met the criteria? That way you have that when it comes back to why you build what you build, and whether you build 31 or 32 in the nursing or office codes. Hopefully I answered all of those questions, because we did have I got 7 of them, 7 Bill. So if I didn't get your question, and I think I did, but if I didn't get it, please put it back in the chat. I'll get back to that one. Okay. There's one that is billed: should swallow studies be billed to the nursing home for a non-skilled patient? The answer is, first, can you tell me which code you're billing? Now, odds are no. Why do I say that? Well, because for the most part, the codes that I'm familiar with for a swallow study is the 70370 and the 70371. Neither one of those should be billed to the nursing home. They're not something that they can do. They're outside that scope. They would be billed to Medicare directly during the Part B stay. Let me make that clear. During the Part B stay. Okay. So just make sure you bill Medicare during that. The next question, they have a lot of ER claims denied for SNF when the correct modifiers are on the ambulance charges. Not really sure if this is an ambulance claim that's denying, if it's an ER claim that's denying. What are we trying to do? But I do want to remind you that there is a caveat with ER claims. for skilled nursing facilities. If that ER claim is not billed with the proper revenue code indicating that it was performed in an emergency room, it can cause that ambulance service to bundle. So even if it was done in an emergency room, doesn't always mean that the facility is going to bill an emergency room exception. So it really just depends. Really just depends. Another question that we received is regarding a physician's office, and why does the ambulance transport revert back to the skilled nursing facility? That's part of the regulations that come into play. So even though a physician's office is not covered when directly billing Medicare, because this is a separate payment methodology and billing system sets of information, it is covered within that. So if the transport is to a physician's office, that transport must be billed back. That is all the questions that I had for pre-submitted questions. Ashley, did we have anything submitted?
We did have a couple of questions. The first one was, we have received denials and recoupments for office visits indicating that the patient is currently in a SNF when a patient comes to our clinic to be seen. Could you please confirm if we should submit a reconsideration and clarify that these visits are not part of the SNF stay?
Okay, so no, you shouldn't, because really when the patient comes to your office, there's certain things that are still, even though they're being done in that setting, or I shouldn't say office, I should say clinic, that still apply to consolidated billing. That's why you have to know the procedure codes, and then you have to go back out and look up the different files. Also, a lot of times testing, laboratory testing, and other things like that that you guys are doing, those we look for and we say, okay, is it professional? Is it technical? Do we have to bill with a modifier TC26? So it's not automatically correct to say, nope, I just need to file and say it's not part of the SNF stay. This is not hospice bundling, not hospice bundling. This is a separate set of criteria, and it's actually a lot more interesting when you get into the ins and outs of it. So I don't want you to get into that habit. Really determine the procedure code. Tell me, is it a professional service? Tell me if it's not a professional service, then what are you doing and what should be billed? Also look at each one individually. If they may be in your clinic, but how many things did they have done, and does each one apply? Some may and some may not. So it's really not a straight cut and dry answer. All right, Ashley, next question.
Right, and the last question we had was, is HCPCS G2211 exempt from 2026 SNF Consolidated Billing for provider-based billing with place of service 22?
All right, so the G2211, I'll just start off as if I don't even know what that is. Okay. A Medicare add-on code. What do we talk about with add-on codes? It's based on the primary procedure code. So what are we adding on this code to? The E&M code, right? So now we got to determine which file that goes into. So you'll have to tell me which E&M code it is. Now, is it a nursing facility code? Is it a ... So then we have to come back out here and we say, oops, I'm sorry. And we say, okay, professional service would always be part B because a facility doesn't do a professional service. We would scroll down. And then, by the way, I'm on the CMS website. I'm just scrolling down. I'm going to go to the part A stays, the professional service stays, because remember, that's what we're talking about. And we can go ahead and open that up. Give me a second here. I just got to get it back open. You can search for it. G2211. What we find out is that a G2211 is a complex evaluation and management add-on code, but it's never billable to the skilled nursing facility. Okay, so then how do we determine which code to bill with it? What type of stay is the patient in? what type of stay is the patient in? That's what we're going to look at from there. So when you're saying, should I bill it with 22? Should I bill it with 21? No. If it's a consolidated billing issue, skilled nursing facility consolidated billing, you're going to be billing a 31, or you could bill a 22 if it's the Part B portion. Okay. So it's very hard for me to kind of go back and forth with that. Hopefully I answered your question. If not, put some more back in chat. In the meantime, Ashley, did we get anything else in?
The only thing we got in was just clarification on the first question asked about the recoupments for office visits, and they just clarified that they're getting denials on the codes 99202 to 99215, and that's what they're seeking clarification on.
All right, so let's go back to the basics, starting with that one. 99202, 99215, not billable when it is a medically necessary Part A skilled nursing facility stay. You have to bill the skilled nursing facility code with place of service 31. Ashley gave us that section within the guidance in the manual. So let's see. Let's take a look at that since it seems to be a question coming up here. We're going to go to CMS website again. Go back to the top. We're going to go Medicare. We're going to go regulations and guidance, not coverage, but regulations and guidance. And we want manuals. Inside there, the internet only manual. What we're going to do is we're going to scroll down and we're going to come to the Medicare Claims Processing Manual, which is 100-04. Now we're going to say, hey, I don't really know where I want to go. We're going to go to the code set for the 1500 because that's what we're talking about, would be a 1500 bill. So this code set right here, this would also apply for those of you that bill on an 837P professional billing. When we come in, we have to look for certain things, okay? Place of service is one of them. Types of service, place of service, 10.5. It's going to go through, it's going to give you a bunch of information, and I'm going to just keep scrolling through because this is all the different places of service. When we get down below the chart, it takes a second to get down here. Special considerations for, we're looking for special considerations, and we're looking for facility settings because that's what we're talking about here. Okay, so this is code 09, prisons and corrections. Nope. Inpatient, registered patient right here. Special considerations for services furnished to inpatient. So inpatient Part A is paying. Okay, so then we know when a physician practitioner services to a registered patient made under the physician fee schedule at the facility rate. To that end, a physician service supplier to a patient who is registered inpatient, that's what we're talking about, shall at a minimum report 21. Well, in this case, we know it's not 21, but if we go on further, you can see down on the next page, it says, for example, a physician may use place of service 31 for skilled nursing facilities receiving inpatient skilled care. That's what we're talking about right here. This tells us I have to use 31, but in order to use 31, I cannot use an office code. I have to use a nursing facility code. So this is where we're getting that information from. So it's very complex. It's like I said, it'd be nice if it was just really easy and super clean and we're done, right? Hopefully that gets you what you need. So when you go to look at 11 versus place of service 11 with one of the evaluation and management office codes, then you also have to take it a step further and say, hold up. Are they in a hospital inpatient, which they shouldn't be if they're coming to you? Are they in a skilled nursing facility inpatient stay? Yes. Number two, is that stay being paid for by Medicare, which makes it a Part A inpatient stay? Yes. Now we cannot bill those codes. We have to bill with 31, which means a nursing code. So hopefully I put it all together. Ashley, did I explain it well enough, or is there something else we should try to add to that?
No, I think you explained it well enough.
Okay,
The
perfect.
same person asking the question, I think, is just still asking for clarification. They said, so then we wouldn't bill with place of service 11, even if the patient was seen in our clinic. And I think you kind of covered that.
Oh, no, do not bill with place of service 11. If it's a SNF Part A inpatient, do not bill place of service 11. That will automatically be taken back when the skilled nursing facility claim comes in. If you do bill, we will take our money back and you are then expected to bill a brand new bill, but you want to make sure that you're billing with the nursing codes in place of service 31. All right, was there any other questions?
Nope, that was it.
All right, perfect. All right, let's get on with this. So, a couple of things to remember. We just keep talking about taking our money back and overpayments. As a reminder, the simplest way to send us money back is to use our website, and that's the SNAP feature, the Secure Net Access Portal. We looked at that already when we looked at eligibility. They also have something called the OCA, or the Overpayment Claim Adjustment. This is where you can actually tell us, hey, take your money back or give us a refund back. Best way to get it back to us, easiest trackable, best way to do it. However, if you do choose to do that overpayment, you can do a paper form, and that's fine. Paper check, whatever you want to do there. Please make sure that you do include our overpayment notification form, and make sure that when you look at this form, across the top there are 3 distinct fields, and I'm just going to try to open the form up here, that you must use correctly. That's this contract field, Medicare type field, and state. So contract, J5 or J8, Iowa, Kansas, Missouri, Nebraska, or Indiana and Michigan is J8, Iowa, Kansas, Missouri, Nebraska would be J5. Under Medicare type, please remember that most of you will be a Part B type in this case. That is the multi-carrier system, billed on a 1500 or an 837P. If you do bill on a UB04 or an 837I, that's when you select Part A. Last state, tell me where they actually sent the claim from, where they were at. That's what we're going to do with that. All right. In a little while, you're going to get an email follow-up, which is going to have a survey link in it. And then also, Ashley just put one in the chat. Go ahead and take the survey. One thing I want to let you know is there's a picture on my screen. It's on the right side, kind of upper. You will see a little external. It's got a little triangle. It's not spam. It's not malware. It's not anything bad. It's just us trying to get you to take the survey. It's 4 questions. So if you got time to take 4 questions, answer 4 simple questions, you can take the survey. If you'd like to provide additional feedback, there will be another question in there, which is your fifth question or so. And that question will say, do you want to get feedback? If so, you can check yes, then go ahead and do that. But we really do want your feedback. Also, if you are listening to this as an encore presentation, you will see a picture of online survey. It looks like the one on the bottom here. It's got a hand with pointing to the top, which has 5 stars next to it. That is a way to indicate just, hey, how do you get to our survey and how do you take it? We want to hear what you have to say. We really do value that information. In a few minutes, you're going to receive an email from us. Don't delete it. Open it up, take a look at it, especially if you need a certificate. If you do need a certificate, it's important to make sure that you look at that email, because the bottom part contains the certificate with contact hours. Contact hours are then given to your governing bodies on whether or not they will accept it for continuing education units. All right, so make sure you do that. If you think of anything in the next 7 days, drop us an email. Again, wps.jj.education@wpsic.com. Throw SNF CB files into the subject line. That just helps us be able to make sure it comes to me directly. We can answer those questions. All right, I'll give you an email response back to that. So thanks for listening. We appreciate you guys taking that survey and providing us any feedback. On behalf of myself and Ashley, we want to thank you for your time today. You may now disconnect.